Good morning from beautiful Ortona South campground, which is in uh, just outside of LaBelle, Florida, and my camper. So we're going to talk about, as the screen says, trauma to the head, neck, and spine this morning. I have another one of these presentations through the AEMT book. And in the beginning of that one, I talk about the fact that the two chapters are presented differently. This one, as you can see, the copyright, this last update was 2016, and the AEMT one, I believe, was 18. But this one is a little more modern in our, excuse me, current thinking and practice with spinal care. And they both present injury signs and symptoms a little bit differently. I don't think that either one of these is superior to the other, except for this one having a big discussion on spinal motion restriction, which is our standard of care now in New Hampshire. It's not in all the states though. And the current, national registry system, program, testing, whatnot, it's still backboarding. So as a student, if this is 2021, December of 2021, if you're currently taking a national registry exam, I would say if your question states your patient was involved in a motor vehicle accident and was ejected, is complaining of lower back pain, your treatment is A, put a collar on him, place him on the stretcher. B, completely immobilize him on a longboard. C, neither. Or D, call for ALS, right? It's B, completely immobilize him. If your question was your patient is sitting up in a car after being rear-ended and is complaining of pain on the left side of their neck, your treatment is A, collar, a short boarding system such as a KED. C, let him stand up, turn around, and sit on the stretcher, etc. Then you've got to pick the full Monty, so to say. The whole collar shortboard onto a longboard. I think that is going to change nationwide. That is certainly the path we're on, but it's hard to get some of our state EMS systems to change. New Hampshire was one of the first ones. Maine, actually, in my memory of this, 1999, Maine went to a spinal assessment program where if their spinal assessment was negative, you did not have to collar and board them. But it was a rule out, like you're going to collar and board them unless. New Hampshire followed a couple of years later, and then, oh boy, 5 or 6 years ago, kind of took the lead nationwide on it's a rule in. In order to have a collar placed, you have to rule into it. Just because you have a mechanism of injury doesn't mean you need to be collared and immobilized. So we'll talk about the differences in that here, I don't know, 50 slides from now. All right, I'm gonna turn my camera off so I have more screen to be able to see. All right, so here we go. Now, I'm gonna bring a little bit of my perspective into this. And that perspective is based on a few things. One, I've been in EMS and an Army medic and a paramedic for 36 years. I've done flight medicine. I've done a bunch of the trauma classes, the PHTLSs. I've done the trauma nursing core curriculum class, which is a pretty good class. And so I've got a lot of other things that I've seen training wise. I was part of the whole New Hampshire rollout of spinal assessment. I was one of the probably first 15 providers in New Hampshire that was part of that, because Frisbee was the trial service for that. And I've been part of the whole rollout of this spinal motion restriction since then. 30 years in the ER, so ER-based EMS, where I've gotten to see a bazillion x-rays and CAT scans and MRIs and exposure to neurologists and neurosurgeons and pick their brains on this. And on Good Friday 1984, I was a head, neck, and spine patient when the car I was in went into some trees in Stratford at the bottom of Mile Long Hill on 202A, and I broke my neck in 5 places. So I've been on both sides of this. Now, in that time frame, we've seen a lot of changes. When I took my registry exam, this short wooden backboard was what we used for immobilization. You had to use straps and cravats and basically aiming to have this position secured this way. This is a KED board. Same thing, it's a short immobilization device, a vest type device. But, look at this position. This does not look very comfortable. And if people go, well, it's not supposed to be comfortable, it's supposed to protect your neck and spine. If you are not comfortable, you will squirm, you will fidget. And that squirming and fidgeting with the small muscles of your back and your neck will move more or cause more movement within your spine than this device is worth, okay? And now we look at patients and say, okay, you have a mechanism, you have some pain over your spine, or you have some numbness and tingling, paresthesias, or you have some paralysis. Therefore, we need to do some spinal motion restriction. We're going to put a collar on you. We're going to hold C-spine, manual C-spine. We're going to put a collar on you, and then we are going to have you spin, stand up out of the car, turn around, sit down on our stretcher, and then we are going to help rotate you so that you are flat on our stretcher in a position of comfort, and you are not going to suffer any ugly secondary injuries due to a board, and long boards still look like this even though they're plastic, or because of that. So we've come a long ways in that time frame. So a little bit of the anatomy and physiology to this. Our nervous system, right? We have our central nervous system, which is the brain and spinal cord. Everything else that comes off of that is peripheral nervous system. So our vertebral nerves themselves, our cranial nerves. So our cranial nerves come out of the brain directly. On old Olympus, towering tops, a Finn and German, viewed some hops, right? If you go to paramedic school, you're going to have to learn that. There are some naughty rhymes that go with it also, but I won't say those. Olfactory nerves, for example, right? Your nose, sense of smell, optic, right? Your eyes. The rest of them come out somewheres between C1 and S5, okay? So thoughts, sensations, motor functions. I think I'm dragging ass this morning, right? It's early in the morning, and I haven't had my full coffee yet. So I think I want a sip of my coffee. I reach over, I can feel the coffee cup, I can feel the smooth bottom part, the rubber grip around the top, and I can then grip it with just the right strength to lift it to my mouth, take a drink, and set it down. Okay, so thought, sensation, and motor function. Now, there are dermatomes that we'll get to. This kind of hints at it a little bit. You can see where the peripheral nerves come off of the central system. And if you imagine damaging something here, well, everything below there is going to be damaged. If you damage something here, below here. But there are actually things called dermatomes that will provide us patterns of injury based on where the cord is injured. So a neurosurgeon or a neurologist doesn't even really need a CAT scan to tell you where you were damaged. They want a CAT scan to say how bad and to make their plans. But if you have an injury, you have numbness and tingling on the front of your thighs, they can tell you where that damage is. And we'll look at a picture of that in a little while. A little review of the head. Our cranium is, what we think of as the skull. It's the biggest portion of your head. It's what protects your brain. Your ear canals come out of it. Your eye sockets, are part of it. And then we have facial bones, everything else. 14 of those. The mandible is the only bone in the head that is supposed to move, okay? And it joins with the temple to come up with the TMJ, okay? So people have pain, TMJ problems, chewing hurts and whatnot. That's where it is associated with that joint and with the ligaments and tendons that make it work. So lower jaw, mandible, upper jaw, maxilla, your nasal bones, zygomas, your cheekbones, and then the orbits that your eyeballs sit in for protection and for movement and whatnot. Spinal cord comes out of the base of the brain and it goes down through an opening in the skull called the foramen magnum. So any hole through bones are called foramens. This one is the biggest, so foramen magnum. And the spinal cord and brain are protected by a fluid called CSF. So cerebral spinal fluid provides kind of lubrication and shock absorption for the central nervous system. The skull itself, the cranium, is made up of different bones. And we have, between these bones, we have suture lines. So when we're born, these suture lines are not fully healed yet. It allows, you look at a baby and you go, oh, he's a little cone head, right? Because it allows that skull to change shape a little bit to make its way out of the birth canal. And over the next months to years, these suture lines completely heal in. So we have the frontal bone, right? Forehead, frontal bone. On both sides, split down the middle, we have a right parietal and a left parietal. The frontal goes all the way across. In the back, the occipital bone goes all the way across. And the occipital bone is in front of, as an example, your visual cortex. So when you fall and bang the back of your head and you see stars, that's because you banged that area that controls vision. Temporal bone. Temporal bone is the thinnest external bone. Okay. Sphenoid, our TMJ here. You can see where the ear canal is, our mandible, our maxilla, our teeth, and then our nasal bones. Okay. Now, my students have heard probably enough of this, but I was taught how to remember this in my EMT class, and our EMT instructor had us chanting 712 554, 712 554. That was 1985. I can still see him doing that right now. But you know what? I remember it. 7 cervical vertebrae, C1 through C7. There were actually 8 cervical nerves, but 7 cervical vertebrae. 12 thoracic vertebrae. The way to remember that, besides 7, 12, 5, 5, 4, is the fact that you have 12 ribs. And, well, since the days of the Garden of Eden, we have 12 ribs. And each rib is associated with a thoracic vertebrae. We have 5 lumbar vertebrae, 5 sacral. The sacrum makes up the back wall, basically, of the pelvis. And then we have 4 coccyx vertebrae, and those make up our tailbone. Now, each has a spinous process. That spinous process looks kind of like a finger of various sizes, depending on where in your spine it is. It could look like a little nub of a finger, or it could look like your pinky coming off the back. And those are attachment points for ligaments and muscles. Okay, so the two most injured areas, cervical spine and the lumbar spine. Cervical spine makes sense because of the fact that you have a 22 to 25 pound basketball sitting on the top of it, and your neck muscles, unless you're Arnold Schwarzenegger when he was 30 years old, your neck muscles are not as strong as the rest of your body is, the rest of your big muscle groups, and they're not big muscle groups. Like your chest muscles, your pectorals, big, strong, your quads in the front of your legs, right? We don't have that in our neck. So we are susceptible to these hyper extension, right? You tip your head back to look up at the sky, you're extending your neck. So hyperextension, which means overextending. You flex your chin down to your chest to look at your feet to see what that is biting you, right? Oh, it's a fire ant, right? Yes, I've been tagged by fire ants down here in Florida, and they suck. Hyperflexion is when you flex too far. We have rotational right, rotational left, looking over our shoulders. So we can hyper extend, hyperflex, hyper rotate any of those. Our lumbar spine is because probably 2/3 of our weight sits on L4, L5. We rotate our torso around. The majority of our rotation ends up around those vertebrae. And if you jump off something, it could be a footstool. You jump off a small step ladder, right? You're 2 steps up and you jump down onto the ground. That force gets transmitted up into your vertebrae. And the first free moving vertebrae that are impacted are your lumbar spine. So very easily injured also. So our C1 is also known as our atlas. These are great little Trivial Pursuit type, registry type questions. C1 is known as atlas, and that melds with the foramen magnum, or is part of the foramen magnum. And the axis, which is C2. So the axis has a little nub that comes off the top of it. Looks kind of like the distal part of your pinky, and the atlas rotates around the axis. So things rotate on an axis, right? So C1 and the skull rotates on C2, the axis, and that little nub helps keep it in place. So that gets broken, you now have an incomplete C1, C2 junction, and instability, right? C1, C2, not good. When we go down through C3, 4, and 5, keeps the diaphragm alive, right? So the phrenic nerves that come out of the neck that control the diaphragm come out of C1, C2. So if you lose C1, C2, you lose the diaphragm and you lose your intercostal muscles, right? Because the intercostal muscles between your ribs come out at each rib. So at C1, C2, you've lost the intercostals and you've lost the phrenic nerve. You have no rise and expansion of the chest wall. You have no contraction of the diaphragm. You stop breathing. Okay, so C3, 4, and 5 keeps the diaphragm alive. And then we have T1 through T12, L1 through L5, our sacrum, and our coccyx. Now, when you get down to here, the spinal cord itself ends as a grouping of nerves, and we get what's called the horse's tail, chordae equini, I believe it is. And the horse's tail is just, it looks like strands of horsehair coming off, right, the ass end of a horse. But those are individual nerves that come out and innervate other areas. And you can see here, it looks like some holes. This is where some of the nerves come out through, as well, blood vessels, whatnot. So injuries, scalp injuries bleed like stuck pigs, right? That's an old school saying, because there's lots of blood vessels in the scalp, lots of small arteries, small veins, and capillaries. And they bleed a lot. And people go, oh, it's just a scalp wound. It's okay. They bleed a lot. Well, they do. Go back to day one of assessment, patient assessment, right? As I walk up to my patient, do I see any significant bleeding? Yes. I'm going to have my partner handle that. Why do we look at the scalp differently? Oh, well, it's just a scalp wound, no big deal. It's still bleeding, and it's still extensive bleeding. If you are my size, right, 5'11", 200 pounds, I have roughly 5 to 6 liters of blood, probably closer to 5 liters of blood in my body. If I lose a water bottle's worth, right, 16-ounce water bottle's worth, that's 350 something mLs, right? That's a third of a liter, okay? If you are my grandson and you're 11 months old, you have about 20 ounces of blood. If you lose 4 or 5, that's a quarter of your blood volume. You are in extreme shock, okay? So significant level of shock. So scalp injuries need to be controlled, just like any other big bleeding injury is, okay? And scalp injuries, I personally think, are ideal for the hemostatics, the quick clots and whatnot, okay? And they can be hard to, if you have a giant avulsion, right, a big flap, like an incomplete scalping, like we had this past summer, that's a lot of bleeding, and it's hard to get under control because that plate-sized flap has vessels that are cut or torn all the way around that, right? So some quick clot dressings and gauze underneath the flap, around the edges of the flap, and then pressure on top of the flap, okay? We're going to see an example of a more, I think of it as more localized scalp injury. Again, quick clot would be ideal for this. Okay, skull injuries themselves, the skull, open or closed, right? Is the brain open to the outside? Open head injury. Is it closed to the outside? So this is, this is probably a 2-inch laceration. Is it gonna, and it's complete, and it goes down to a skull fracture, okay? So, with the fracture, if it's obvious and it's depressed, I don't think I'd want to be putting quick clot into it. I actually probably have to research that a little bit more. But without the skull involvement, this is ideal for quick clot, right? You pour a packet of quick clot in there, or you take a quick clot dressing or gauze or whatever, and you put that in there, and then put a dressing over the top. Now, direct injuries and indirect. So I shoot you in the head, I stab you in the head, I hit you in the head with a baseball bat. So if I hit you in the head with a baseball bat, if it breaks the skull and those pieces end up puncturing the skull from direct force, that's direct. Indirect, I fall, I bang my head, I have no fractures, I might have a laceration, but the brain bouncing around inside that skull bucket, the cranium, receives indirect energy transfer, and it's indirect injury. So TBIs, traumatic brain injuries, we've started rethinking this since kind of the earlier days of Iraq and Afghanistan, as well as a notable Hall of Fame football player died. Mike Webster, center for the Pittsburgh Steelers, died homeless. It wasn't because he was broke. It's not because he didn't have a home. He just kind of, I guess, from what I've read, didn't feel like he fit in. And everybody was shocked when they found out about this. And why? Why would Mike, Well, because for 10 or 15 years, in the center of an offensive line, he took a ton of hits to the head, helmet to helmet and whatnot, helmet to ground. And over the course of time, even though he may or may not have realized it, he suffered damage to his brain. We were finding this in Iraq and Afghanistan with all these IEDs, the shock waves, the Humvees being picked up and bounced around and flipped over and banging your head and your helmet. And, they found that concussions have some very significant effects down the road. And so how do we tell? Is it a concussion or is it a head bleed? Is it increasing intracranial pressure? Well, we need a CAT scan for that. And we obviously don't have that in the field. So if we see any interruption in normal functioning of the brain, we're going to just simply call that a TBI. They get knocked out, they wake up, everything seems fine. You got to think head bleed, okay? They get knocked out or don't get knocked out, and they do that whole, where am I? What happened? Where am I? What happened? Where am I? What happened? That is a very typical symptomology of concussions, but you still have to assume the bleeding or swelling in there, okay? So we get the CAT scan at the ER, and we see no obvious signs of injury. We see no bleeding and no swelling, no infarcts, right? And dead tissue. And we go, okay, it's a concussion. How can I describe that to you best? Well, if you take your non-dominant hand, in which case that's my left hand. I'm going to turn my camera on for a second. Okay, my left hand, and I take my right hand and I punch it hard. I get pain, I get some numbness and a little bit of tingling, and I get kind of the shooting sensation, pins and needles. But I look at it and I go, there's no swelling, there's no bleeding, there's no bruising, there's no lacerations. My hand is concussed. That is a concussion with the brain as well. All right, so we can have contusions, which are bruises. Contracoup is a description of the motion that the brain is undergoing at the time of injury. So when you get bounced forward, when you come forward and come to a stop, whether it's because you hit something or just the muscles stop you, that blunt force at the front of your brain is called coup, okay? When your brain sloshes its way backwards on the other side of the injury and bangs against the inside of your skull, that's contracoup. So you can have a coup or contracoup injuries or both, okay? With this blunt force, the brain develops a little bit of a bruise, that's a contusion, okay? A lot of times, unconscious, decreased level of consciousness, okay? Concussions, mild injuries, usually no detectable brain damage. There is no detectable brain damage in the beginning. Now, you may have MRIs after the fact and go, oh, well, yeah, we can see where, this, or an EEG, and we can see some power. Okay, so there's lots of imaging after the fact that might show stuff up, but in the ER, we're not going to see anything. Because if we did, we're going to go, oh, well, that's a contusion, that's swelling, that's a hemorrhage, and you're going to be treated differently for that. You may get knocked out with a concussion, absolutely. You may very well have a headache, be a little groggy, short-term memory loss. That, where am I? What happened? Where am I? What happened? They know who they are. They know where they were coming from. They can't tell you where they were going. Okay, that's very common. And that will go on for the entire ride to the hospital. It gets pretty annoying after a while. So we can have lacerations of the brain. Inside of our skull, that cranium is not a smooth surface. There are small ridges inside the skull that are attachment points for ligaments and tissue that helps hold the brain in place, okay? The dura mater, for example, okay? So we have hematomas, right? We have areas of bleeding, right? If you bruise your leg, somebody smacks you in the thigh with a golf ball, you are going to have a bruise. That is a hematoma. That is bleeding within the tissues. So with subdurals, epidurals, intracerebral, we can also have subarachnoids. And what that means is sub is below that lining. So the dura mater is the outermost one against the skull, and it provides attachment points. And subdural would be a little bit of bleeding below it. These typically are small vessels, small veins, small capillaries, and it can take 6 to 8 weeks for that patient to be symptomatic. They can be symptomatic immediately, of course, but with a small, slow bleed, 6 to 8 weeks is not uncommon. So when we talk about history of the present illness, right, we get the OPQRST and the sample history. E under sample, events leading up to it. Right. Well, what were you doing when your headache started? I was sitting on the couch. That doesn't tell you squat. But if you say, boy, you've got the worst headache of your life, it just came on 3 hours ago, and you're puking your guts out, do you have any migraine history? No. Okay, E, events leading up to it. What were you doing when it started? I was sitting on the couch. E question. All right, so tell you what, in the last 2 to 3 months, because people don't always get time frames right, in the last 2 to 3 months, have you had any accidents? Have you had any falls? Have you been beat up, right? Tumble down the stairs, trip and fall on the ice, anything like that that you can think of? Oh, well, you know, I don't know, a month and a half, 2 months ago, I did miss a step coming down the stairs, and I did fall, and I banged my head against the table. Really? Did you get knocked out? No. Okay. It's a subdural head bleed. Okay. Thunderclap headache, just the worst headache of my life. Nausea, vomiting because of the pain. Very common with those. Okay. Now, epidurals are above that. They're between the dura mater and the skull. And these tend to be fairly significant. They tend to be bigger vessels because between the dura mater and the skull, we have arteries and veins that feed brain tissue and that go into the skull. Okay. And vice versa. So they shear because of this Contracoup movement, and they tend to be bigger vessels. These people tend to be more symptomatic more quickly, like on scene, altered level of consciousness, unconscious, whatever. Intracerebral within the brain tissue itself. The arachnoid mater is the innermost lining, and you can have subarachnoid also. Those people tend to be more symptomatic quicker as well. So patient care, God, the standard first couple of lines, right? BSI, scene safety, right? So standard precautions. All injuries above the collarbones, the clavicles, assume cervical spine injury until proven otherwise, okay? Any mechanism that imparts energy potentially to the spine, think of the entire spine. ABCs, right? I can't stress ABCs enough to people because we skip over them a lot. And people go, oh, that's horseshit. No, we don't. Yeah, we do. We get distracted by the fact that, oh, their femur's sticking out of their jeans, and we forget to assess the A. Or, well, we know the airway's open, but we don't listen to lung sounds and find out that half of the B isn't there, okay? So ABCs, if they took a blow to the head, and they are unconscious, get ready for some breathing issues, okay? Some ventilatory issues. If indicated, right? So cervical collar. And we're going to go over a little bit of an assessment at the end of this to help you decide when we do and don't collar. Because with the way our protocol sits now, well, we can sit them on our stretcher, so we'll just collar everybody. That's a pretty common, well, I'll get a collar. No. Hold on there, Skippy. let's do an assessment. Do they need the collar? Okay, so we'll go into an assessment for that towards the end after we talk about collar and board everyone. All right, control bleeding. Keep them at rest. We don't want them walking around. Emotional support, well, damn, talking to conscious patients, that should be everybody, not just head, neck, and spine. Treat open wounds, treat for shock, get ready for vomiting, and transport promptly to the appropriate facility, okay? Vital signs every 5 minutes, because until proven otherwise, they were brain injury, right? TBI. Now, intracranial pressure, we have intracranial pressure in our skull now. And our blood pressure has to be enough to overcome the pressure that's within this closed space so that we can perfuse our brain tissue. Okay. I want you to think about a milkshake. And I want you to think about trying to blow bubbles into the milkshake when you're a kid or you're a bored adult, sometimes like I am. And you know that if you blow softly into the straw, nothing happens. Okay, so that milkshake is the intracranial pressure within your skull. You have to get enough pressure within the pipes, the straw, blood vessels, to get oxygen into that tissue. Okay, so a thin kind of watery milkshake, right? It's melted mostly, takes a lot less. But as if that pressure, you throw that back in the freezer and that freezes up again, that pressure climbs, you need more pressure to get in there, okay? So as our pressure builds in the skull, in the brain tissue, we start to compress that brain tissue as well. We can't perfuse it as well, which gives us secondary ischemic / hypoxic injuries, but also we are compressing those tissues and we're causing damage to occur. And depending on the size of the vessel, it depends on the time that it takes. Now, rising intracranial pressure. You'll start to see the blood pressure climb because that blood pressure has to overcome the increasing pressure within the skull, right? You have to blow harder and harder and harder into the straw, okay? And the heart rate starts to drop. I think of this as a protective measure. It's kind of twofold. One, you're affecting the control centers in your brain, but also the carotids are going, ooh, blood pressure is climbing. I need to slow things down a little bit, okay? So you get rising blood pressure and dropping heart rate, which is known as Cushing's reflex. Now, this is super obvious when you see it, right? If you're trending your vital signs, right? You're on the side of the road and this kid came off his bicycle and banged his head on the pavement and he's sitting up talking to you, you get your first set of vital signs. You don't wait 10 minutes to get in the truck and get your first set, because your first set of vital signs might be 112/70, right? 15-year-old kid on, on a bicycle or a skateboard, 115/70. 10 minutes later, it's 128/80. Well, 128/80 is a normal blood pressure, so we don't think anything of it. But if we looked at it in view of the first one, it's already climbing. 5 minutes after that, he's confused and it's 136/80. Well, 5 minutes after that, he's unresponsive now and he's 180/80, okay? So having that first 10 minutes worth of knowledge it can be very important to us. That's the difference between us taking him to the local ER and us taking him to Portsmouth, which is a trauma center and has a phenomenal neuro ICU, a neuro center. Okay, so get your first set of vital signs quick. Altered mental status, dilated pupils or sluggish reaction. So you have your unresponsive patient and you are doing your primary assessment and their A's okay, but they're unresponsive, we put an oral airway in, right? If they don't accept that, they gag a little bit, okay, so that's kind of painful response. I'll put nasal airway in, jaw thrust. Are they breathing adequately? Yes, no. Yeah, yeah, they're breathing okay. Good, lung sounds are good. Okay, great. How's my pulse? Right? Oh, my pulse is 60. Does that fit a traumatic injury? No, right? So now get my blood pressure. Oh crap, blood pressure is 200 over 100. And now I'm going to do my head to toe, and I check my pupils, and I go, oh my God, the pupils are huge. We call those blown pupils. When the pupils are as big as they can get, blown pupils. Okay, especially the fact that it's noontime and the kid's facing the sun, his pupils should be tiny. Now, Cheyne-Stokes breathing is Cheyne-Stokes and ataxic. We tend to kind of probably inappropriately refer to both as Cheyne-Stokes. Cheyne-Stokes is a pattern where you have long apneic pauses that can be like 15 to 30 seconds long, where they're breathing and then they're not breathing. And you go, oh crap, and then they're breathing and they're not breathing. Ataxic is irregular. So I mean, I know I tend to think of ataxic as Cheyne-Stokes, but technically, ataxic is an irregular pattern. They may speed up, they may slow down. You may have these apneic pauses as well. So, okay. Central neurogenic hyperventilation, I think of those as Kussmaul's. Okay. Decorticate or decerebrate posturing. So as the pressure in your brain, either from bleeding or swelling, builds, the biggest hole in your skull is your foramen magnum. That is where your brain stem connects to your spinal cord. So as that builds up, it tries to push the brainstem first, out through the foramen magnum. That is herniation. Anytime you have an organ that is coming out through a hole it's not supposed to, that's herniation, right? You have a hernia in your groin, right? You have a loop of intestine in your scrotum. You have an umbilical hernia, a loop of intestine coming out through the little hole where your belly button is, herniation. You have your brainstem being pushed into your spinal cord, herniated brainstem. We start to get these bad respiratory patterns. We start to get posturing. And what I mean by posturing is the body manipulates itself, the brain manipulates the body into certain positions. Decorticate, decerebrate. Decor, so core, towards the core. Decorticate is the arms and hands coming in. My camera back on for a second. So the hands kind of the fingers come into the core, make a fist. The wrist flex in towards the core, and the arms come in towards the core. Ooh, it caused a cramp. Decerebrate is out and away. Okay, so out and away is first, decerebrate first, followed by decorticate. So you're thinking, all right, is this serious? Is it potentially serious? They go to a trauma center. If that thought even crosses your mind, they go to a neurologic trauma center. All right. You can have a level 3, like in the state of New Hampshire, a level 3 Parkland, for example. They may do good stabilization of your typical multi-system trauma patient, but they don't have neuro. So why would we take them there, right? Well, I'm 20 minutes to Parkland. I'm 40 minutes to Portsmouth. Portsmouth, right? Dartmouth and Life Flight of Maine fly traumatic brain injury patients to Portsmouth. That tells me, damn, I should be taking them to Portsmouth, okay? One of my paramedic instructors said, if you think maybe I should do something, or you think maybe they have something, they do, or you should, because it's your subconscious brain recognizing something that you've either heard about, read about, seen, smelled, whatever, and it's trying to get your attention. So, oh, geez, should I? Yes, you should. Okay. Does their injury warrant stabilization of the spine? Is immobilization warranted? Well, we'll talk about that. Anything impaled objects, stabilize it in place. A lengthy object may have to be cut, but that's a whole nother class, right? I mean, immobilizing it so it doesn't wiggle, cooling it so it doesn't heat up. It's a lot of work. Facial, I tried to say face and facial. Facial and jaw injuries, primary concerns are airway. Position to allow drainage. So a good example of this was a guy who put a rifle under his chin, reached down with his finger, his thumb to pull the trigger, and when he did, he moved the gun off angle. So instead of blowing the top of his head off and his brain with it, it went in to the left side of his jaw, blew half his jaw off, half his tongue off, cheek, orbit, and it was a high-powered rifle, so a ton of tissue damage. And this was before we could RSI, before we had IOs. We couldn't get a line in the guy. Didn't even think about trying to intubate him because he's wide awake and all that exposed raw nerve tissue. So we positioned him left side down, left lateral recumbent, recovery position on the stretcher, and let the blood drain. And we were busy trying to do stuff for him, right? So I had him stick his hand out when it feels like you need to be suctioned, right? Because he knew what choking on his blood felt like. When you feel that blood starting to build up, because even positioning, it was still building up in areas and occluding his trachea. I want you to stick your hand out, get our attention, and put your fingers out and start to make a fist. And before you get to a fist, which is I can't breathe, I will suction that out for you. And what he would do is he would sit there, make his fist. I'd be suctioning. He'd open his fingers up slowly and put his hand to his side. Okay, so you need to be creative. You need to use positioning to your favor. Non-traumatic brain injuries can, your stroke patients, right? We have two types of stroke. We have an ischemic stroke caused by a clot. Blood flow doesn't move, and so we become hypoxic and we have a stroke. Or we have a hemorrhagic stroke. We blow an aneurysm, okay? Signs and symptoms are the same, except there's no trauma involved. Glasgow Coma Scale. If you go into a trauma center nowadays, at least the ones I'm associated with, they will ask you, hey, do you have a GCS for us? Crap, hold on, okay? So it would be nice, it would be ideal to memorize those 3 parts of the Glasgow Coma Scale, right? But what I recommend, we have enough other crap to remember in EMS, take that Glasgow scale and tape it to the wall of the ambulance right next to your microphone. So when you reach for your microphone to call the trauma center, you go, yeah. 13. So, hey, Portsmouth Hospital, Action Ambulance 3 calling priority 1 trauma alert, right? Trauma team activation. And you start right off with, hey, I've got a 47-year-old male responding to verbal stimuli. He's got a GCS of 13. Boom, it's out of the way, it's done. Okay, so eye-opening. Do they open their eyes appropriately? Are they open? Are they looking around? Do they open to verbal response, right? Do they open to pain? Do they not open at all? Verbal response, are they oriented? Oriented. Are they confused? Inappropriate words like the sky's purple. What? Incomprehensible sounds, just grunting and groaning. Or is there no verbal? And motor, do they obey commands? Do they localize? Do they pull away from pain? Or is there none? Okay, so the best score is 15. If you are unresponsive, you are not responding verbally, you are not responding at all motor-wise, and your eyes do not open, you have a Glasgow score of 3. Abraham Lincoln today has a GCS of 3, right? So think about that. Your Coma score with a heart rate and a pulse, your Coma score is the same as a president who's been dead for 160 something years. That's kind of spooky. Okay. You don't need to calculate this on scene, right? But in the truck before you call, I would. And there's also, I mean, if you think about this, you have a Coma score of 14, you have altered mental status. You have a symptom of a brain injury, all right? There's another old saying, less than 8, intubate. So if you have a Coma score less than 8, you can't maintain your airway, you could probably intubate him without RSI. Now, wounds in the neck, excuse me. In the neck, we have large vessels that lie close to the surface. An artery that gets punctured in the neck is going to spray blood, and you're at risk for bleeding to death. A large vein, such as your jugular vein that lies even closer to the surface, has the problem that its atmospheric pressure is lower than the air outside, and it will actually suck air into the vessel, and now you have air floating around your vasculature. Air bubbles work the same way that clots work. They occlude vessels. Okay? You could have a large air embolus in your pulmonary circulation and have just obstructive shock. Okay? You could have an air embolism in a coronary artery or in your brain and have an MI or a stroke. So we need to try to control bleeding, and we need to put occlusive dressings on top of those wounds in the neck, okay? ABCs. Immediately take your gloved hand, put it over the wound while somebody else gets you something that you can put over the occlusive dressing. Place the dressing over the occlusive dressing. I don't know how that's going to work very well on controlling hemorrhage, but apply pressure to the dressing. So you got to be a little careful putting direct pressure on the neck because you can cause strokes. You're not going to occlude the airway. I mean, you can get strangled by a big dude and still breathe. It's the fact that he's stopping blood flow in your carotids or your jugular veins that's causing you the issues. Okay. Neck wounds, quick clot, yeah. Immobilize the spine if the mechanism of injury. So when I was a younger fellow, any gunshot wound to the chest, belly, or neck, you have to immobilize them because the spine's potentially damaged from the shock waves. No, they're not. Okay, so if the holes line up, hole A and hole B lines up with spine C, then yes, you immobilize them. But if it doesn't, then you don't have to. Injuries to the spine, certainly assume initially based on mechanism of injury. Windshields, diving injuries, right? Reaction impact, right? Contracoup stuff. Here, hold my beer, and then you do something stupid. So assess a mechanism of injury. What is their physical condition, right? So as I walk up to him, what do I see, hear, and smell, right? Well, it's obvious he got rear-ended, and when he got rear-ended, he got pushed into the car in front of him. He's sitting in the car, sitting up, looking around. Great. Or he's standing next to the car, looking around. He's got his phone out, looking up his insurance information. Cool. He's sitting in the car and his head slumped forward. Not cool. High risk falls. So this is funny because depending on what you read, high risk falls, like this says roughly 3 feet or down more than 5 stairs. But trauma center inclusion talks about right? 18 feet, 15 to 20 feet, 3 times their height, all this stuff. That's for multi-system trauma. You fall more than 3 feet, you're at risk for head and neck. This is kind of on the low end, mind you, but axial loading. So your axis is your central nervous system, um, and the bones, long bones. Think about axial loading is force that gets transmitted up a bone. So you land on your heels, you're shoveling snow off your roof, and you slip, and you kind of catch your balance coming off the roof, so you don't fall face first, but you land on your heels. That force gets transmitted up your heels, through your tib fib, through your femurs, through your pelvis, into your lumbar spine, and then further up. Okay. Diving, you land head first, and that axial load runs down your C-spine. Okay. Motor vehicle crashes, high speed, rollover or ejection, absolutely. Anything that forces movement of the spine beyond its normal. So if you say hyper, that's that energy. Whiplash is forward, back, forward, back, forward, back. And while that can cause your TBI with the whole bleeding swelling, it disrupts and causes trauma to the discs in your neck, the discs that are between your vertebral bodies. It causes damage to your vertebral bodies. It causes fractures of that spinous process, and it causes disruptions of tendons and ligaments. And you can have stretching of the cord and the nerves at that point. Most people think of whiplash as you get hit from behind and you go, oh, a new Corvette, I mean my neck. True whiplash injuries can have symptoms lasting for years. Everything from headaches to numbness and tingling in arms and legs, okay? To memory problems, the whole works, okay? So don't just write it off as, oh, the guy's looking for insurance money. Certain medical conditions, okay. Now, also high risk. Any motorized recreational vehicle, ATVs, jet skis, boats, motorcycles, okay? Anything else that you look at and go, oh, crap. If I look at somebody and go, oh, crap, then that is my subconscious saying, you now have a high degree of suspicion that we have a significant mechanism of injury. Pain and tenderness, absolutely important. Now, sir, do you have any pain in place? Yes, in my neck. And everybody goes, oh, I'll get a collar. Is it over their spine, or is it on the side of their neck, on their trapezius muscle, right? Their head got kind of jerked to the side, and that muscle got strained a little bit. That's not a spinal injury, okay? So pain and tenderness over the spine. Now, I mentioned dermatomes earlier. Body surface, body areas get innervated by different spinal nerves, and we can certainly use it to identify loss of function. So here, this is a great diagram of this. You can see that C3, 4, and 5 keeps the diaphragm alive, okay? You can see that sexual organs and defecation organs, shall we say, right? S2, S3. Well, if you lose S3, S4, you lose the ability to not lose your bowels, right? You lose T12 to L1, and everything below there gets taken out. The front of your legs, L1, 2, 3, 4, and 5, down the front of your leg, front of your foot. But the back of your legs, back of your legs are S1, S2. So you could take out S1, S2 in your pelvis and lose feeling to the back of your legs, but not the soles of your feet, and maintain feeling, sensation, motion of your quads and your anterior lower legs, but lose it on the sides. Okay, so I can remember I had a patient who I thought was faking this. He had some motion in his feet, but said he couldn't feel anything in it. And I was younger and I didn't quite realize that there are times where you will lose sensation but not motion, depending on what part of that cord is damaged. And so I was doing, a Charbardel here, couldn't tell me. Charbardel couldn't tell me. So I took an 18 gauge needle. Charbardel couldn't tell me, couldn't tell me, couldn't tell me, couldn't tell me, couldn't. Oh, right here he could feel it. Okay, great. Well, when I went out to the sides, he could tell me. So, like right here, coming down the inside of the leg, he could tell me all the way here, but he couldn't tell me on the outside coming down across, right? So dermatomes, we don't need to memorize dermatomes, but just having an idea that, from here down, that's a dermatome. If you lose T1, that does not mean shoulders down, but you might lose the insides, the anterior portion of your forearm and your arm and your bicep. But because you have C5, you can still move your fingers and have full sensation. Okay, so just something to keep in mind. Our assessments, do they have paralyzation? Do they have numbness and tingling, which is paresthesias, changes in neurological function? Pain with or without movement? Anywhere that they have pain or tenderness along the spine itself, and do they have impaired work of breathing? Priapism. So if they lose nervous control of their vasculature in that area, then they have priapism, right? Well, that looks to me like, well, okay. So loss of bladder or bowel control, S2, S3. Do they have any deformity along their spine? And do they have hypotension, hypoperfusion, right? Do they have compensated shock or decompensated shock? And in this case, it would be neurogenic. And remember that the loss of the nerves loses control of the blood vessels. So the vasculature dilates with the same amount of fluid in it, the pressure within those pipes drops. So our goal is to fill the pipes and to have somebody of higher training, whether it be a medic or an ER staff, start a pressor to make those vessels constrict artificially, right? Keep in mind that older adults tend to have weaker bones, which also means their spinous processes, their vertebrae are also weaker and may be brittle and can have spontaneous fractures as well. They turn and their hip breaks. They twist and they damage something. They bend over and they compress a vertebrae. So patient care and line stabilization, AVCs. If you think they need a collar, then we apply collar. CSMs in all four extremities, before, during, and after any sort of splinting, which includes boarding somebody, includes immobilizing somebody, and it's part of your rapid trauma exam. Apply said appropriate device and then reassess, right? A cervical collar is a splint. CSMs before, splint, CSMs after. Now, spinal immobilization. We used to collar and board everybody. Everybody. You got rear-ended and you had no neck pain, no back pain. Doesn't matter. You have to be in a collar and a board. Because we thought, well, you might have damaged something, and therefore we're going to prevent you from moving it, or it might be almost damaged, and if you move, then it becomes damaged, right? You weakened it, and if you twist, boy, that vertebrae can snap. That doesn't happen. In the late 90s, there was a study in the ERs called the Nexus study, and they did hundreds of ERs were involved with thousands of ER docs and tens to hundreds of thousands of patients. And basically what it said was, or what their findings were, if you have neurological damage in the car, we're not going to make it worse moving you. If you do not have neurological damage in the car, we are not going to give you damage by moving you. Okay? And there are far more horrific events that can happen by being on a backboard. Okay, hypoxia. Hypoxia might be I can't breathe while lying flat, or it might be the pressure on the skin from that board against a bone causes that tissue to become hypoxic. Okay, shock, hypoglycemia to the tissues. Okay, this was in a magazine from 2004, a medical journal, and this was a young, healthy male, as you can tell, who was on a backboard for, I believe it was 5 or 5.5 hours. And the tissue on over his sacrum was compressed against his sacrum, and it became hypoxic, and boom, he developed the bed sore from hell. Okay, so he was unresponsive, and so they just left him on this board, making it easier to move him and take him from the ER to CAT scan, and CAT scan back to the ER. No reason to leave him on the board, but it's easier to move him. And now he goes to pre-op, and then he goes into the operating room, and they log rolled him and found this. Okay, think about the little old lady with very thin skin and no real subcutaneous tissue to speak of, and you can see and feel each vertebrae down her back. She's going to have potential for these sores all the way up her spine. Okay, so don't backboard people. If you need to move somebody using a board, okay, but you get them on the stretcher, get the board out from under them. This is why I now like, for my trauma patients, I like the scoop stretcher. One, I can get them on it fairly easy, excuse me. And two, once they're on my stretcher, if I want to, I can take them off of it. But the other thing to remember with the scoop is it's concave, okay? And the center of it doesn't have any metal. So this area, the spine, the knobs of the spine are actually in open air. You're not gonna have this issue, okay? So scoop stretcher are far better. So what we're using now is a term called spinal motion restriction. We have a natural curve to our spine. Does a backboard allow for that? No. So we used to teach, well, we still teach, if you're going to backboard people, you need to pad the voids. If there is an open space between the spine where there's a curve and the board, you should be putting blankets or towels in there. People don't do it. We've gotten lazy over the years. And now that spine starts to straighten out because of the weight of the abdomen, and that causes low back pain. When I got in my car accident, I was on a backboard for hours, and my back didn't hurt during the accident or after the accident. My neck did. But after a couple of hours on a backboard, my back was killing me. And I was waiting for a CAT scan, and I was like, hello, hello, hello. Nobody, right? I said, the hell with this. I unstrapped myself, got up, went over and laid on a different stretcher. They lost their minds. They injected a ton of, I believe it was Demerol and Visceral into my thigh, which put me to sleep, made the pain better. They put me back on a board and CAT scanned me. Horrific pain. Okay, so worse than my neck was. My neck was broken in 5 places. My back was fine. Okay, so if you're going to board somebody, please remember these curves and put something in those areas where there is no skin touching the board. Now, first step, whether we're going to board somebody or just restrict motion, you got a manual stabilization. Put your hands, whoever's behind them, if they're standing up behind them, if they're sitting behind them, if they're lying on the ground above their head or beyond their head, put your hands on the sides, okay? We're going to have an appropriately sized cervical collar for them, and we are going to use that in conjunction with something else. Now, if you're just doing motion restriction, that's just the stretcher, okay? Remember, no collar eliminates movement, because you put a collar on sized perfectly, you can still turn your head and wiggle it and stretch it and whatnot. So you also have to verbally tell them, hey, listen, I'm going to put this collar on you. I know it's not super comfortable, but I need you not to move around, okay? Although backboards remain useful, the stretcher is appropriate for this. Stretcher and straps. if the natural curvature of the spine is followed with the stretcher mattress. And again, we're not going to make their injury worse. We're not going to create a new one. Rigid spine boards are still commonly used, though. New Hampshire played around with these vacuum boards, vacuum mattresses. Looks like kind of a vacuum splint for the spine. But when the studies all came out and said, no, you don't need to do this, they said, okay, we're not going to do it. Okay. So cervical collar. Now, as far as sizing a collar, I know the books talk about, oh, well, put your fingers here and then compare it to the collar. Why? Why are we comparing their collar size to my fingers? I take a collar and I go, I think they're a no neck. I think they're a small. I think they're a medium. I think they're a tall. And I put it to that size. And then I tuck it under their chin. And I go, nope, that's a little small. I make it bigger. Or that's too big. I make it smaller. And then I clip the tabs in place, okay? So that way, this thing fits her perfectly. So you can see he is holding cervical stabilization, not letting her move her head forward, back, or side to side. Okay, so make sure the collar's sized appropriately. If they are, let's say they're prone, they're face down and their head's turned to the side, we need to log roll them onto their back and then put their head into neutral alignment. Okay, so we want their nose midline down their sternum, down their crotch, right between their legs. So we're going to log roll them and put them into that position. For kids, use the appropriate size collar. If you don't have that collar, or a lot of kids won't let you collar them, and what's going to cause more issues? Them fighting and screaming and kicking and thrashing their head around and pulling on the collar, or simply maybe putting a towel around them, their neck, which is more comfortable, and it's still going to immobilize them, and manually maintaining that position, okay? Now, seated patients, this is old school, right? If they're low priority, they're stable, we're going to use a short board or a vest, a KED board. Nowadays, with spinal motion restriction, if you're allowed to do that, we're going to put that collar on, we're going to hold their head, and then we're going to say, sir, I want you to turn in your seat sideways if they're in a car, right? I want you to turn sideways in the seat, okay? I want you to stand up. I want you to turn around, sit down on our stretcher, and we're going to help lay you down and rotate you, okay? Because it turns out that their standing, turning, and sitting causes less manipulation of the vertebrae than us yanking on a splint that's around their torso. Kind of makes sense if you think about it. If you have a broken arm and you put a splint on their arm, how do you move them? Do you grab the splint and yank on it? No, because it would frickin' hurt, right? I'd punch you in the head. So why are we using a splint for the spine to move people? It caused a lot more issues than just having them stand, because anatomically, that's how they're built. They are built to turn, stand, sit, okay? If they are high priority, this is, they're unconscious in the vehicle, we are going to yard them out of the car. And what do I mean by yard them? We are going to hold C-spine, and then we are going to kind of reach in underneath their armpits. Somebody else is going to grab their legs. We are going to physically turn them in the seat, and we are going to lower them flat, and we're going to slide them out onto our stretcher. Now, this is a great use for a backboard, because we can use that backboard as a shelf to slide them from the seat out to the stretcher. And then I'm getting rid of the backboard, okay? I'm not leaving somebody on a board. I'm just not doing it, okay? So that would be rapid extrication. So our vest style, you saw pictures of those in the beginning. Sequence to follow. So you get that in behind them, and you, so the AEMT students still have to be tested on shortboarding. So if you are my AEMT student, we're going to do this. If you are not, and you're just watching this for either Con Ed or whatever, and you're going, or to help you study for your exam, you need to make sure you know how to use this KED board. So when we secure it, we do the torso first, the head last, right? So long board, torso, legs, head, and arms. KED board, torso, head, and neck, okay? We need to assess their back, all of their back, before we put them on any sort of immobilization device, because there could be holes there. There could be flail segments there. There could be lacerations. One of the things that's always upset me or concerned me, I guess would be better, about doing paramedic intercepts is I show up and people are already secured on the stretcher. It might just be the stretcher. It might be a short board and a long board. It might just be a long board. And I look at them and I go, hey, how'd the back look? Right? Because they're still got all their freaking clothes on. How'd the back look? And they go, okay. That's not what I asked you. I asked you, how did the back look? And I know immediately they didn't assess the back. So now, guess what? Undo friggin' everything, and let's log roll him, and let's cut the clothes off, and let me look at his back. Because I do not want to show up at an ER and have the ER doc come out and go, hey, where's that medic? Yeah, over here. Hey, nice job, asshole. You missed a hole in his back. That's why we're bagging him now. Okay? So you got to look. I think I'd quit at that point. So the EMT applying the board must arrange it without striking or jarring to fit between the arms of the rescuer when stabilizing the head from behind. This was one of the other findings of these studies, is that placing this KED board behind the patient, you got to picture yourself sitting in a car, sitting with your back against the seat. And these seats, by the way, have anatomical shapes to go with your spine, right? You have adjustable lumbar support to take up that gap. And now somebody else is going to hold your head. They are now going to stick a hand behind your back and one on your chest. And they are going to push you forward, push and pull you forward in the seat 4 or 5 inches. Now we've got to lift your arms up out of the way, and we're going to wiggle this 3-foot long board looking thing in behind your back and out around underneath your arms. Then we're going to lean you back. Then we're going to secure everything, and then we're going to yank on it to get you out of the car. It's complete horse shit. The uppermost holes, if you're using an old school board, need to be level with the shoulders. The base cannot go below the coccyx. These KED boards don't fit everybody either, okay? Don't put a strap over the mouth. And this says never place it on the chin. It's a chin strap. Anyways, because it can cause airway problems. Guess what? He's secured to this thing with his head tied back, and he's got a collar on. He's not going to vomit very well. This was another finding with this, is that we had far more airway issues with people immobilized. Like if, right, ABCs, A comes first. If you don't have a patent airway, it doesn't matter about your neck because you're going to be dead, right? So we've got to maintain an avenue for them to be able to puke. Avoid tightening the first torso strap too tightly. But in the test station, if you don't tighten these straps down and that KED board wiggles, you're going to fail. But if you tighten it too much, you affect their ventilation. Do not pad between the collar and the board. This creates a pivot point. But these KED boards have neck pads that are made to go in place because you can't hyperextend the neck. Anyways, so don't use excessive padding like, the commercial pad that comes with it. So here's the KED board. You can see it's in behind her. And now it's just, it's garbage. They're horrible. All right, log roll the patient. If you're going to put them on a board, we log roll the patient. Look at their back. Right. So how do we log roll? With person at the head holding C-spine. That person controls movements verbally. Okay. Now we have somebody with their hand on the opposite shoulder and on their hips. We have somebody by the pelvis with a hand between those on their ribs and down on their thighs. And then we have somebody down on the legs. And on the count of 3, we're going to roll them up onto the side closest to us. Somebody has to lean over, look at the back. Somebody else has to slide the board in underneath them, against them, so we can log roll them onto the board. And they're only half to 2/3 of the way on the board. So now we need to move them on the count of 3, down and over towards the foot, and then up and over back into the middle of the board. And we are manipulating that spine crazy like. Okay. Then we're going to secure them. Torso, because that's the spine, right? We secure the torso first, and then the pelvis. So torso, legs, then we do the head. So that way, if we're doing the torso or the legs at all and we move them, we don't want the head strapped down, not able to move. So the head can move with the torso. Then we secure the head. If they're pregnant, oh, here's another issue. If they're pregnant, we can't leave them flat on their back because the baby and all that fluid around the baby pushes down on the vena cava and causes supine hypotensive syndrome, right? The blood does not get back to the heart and they go into shock. So we have to tilt it to the left. Straps across thighs, pelvis, chest. All right. If you're doing a 6-year-old, now if you're going to secure a child, and this goes for simple motion restriction too. If you have a kid collared, remember their heads are proportionately larger. If you put them flat on their back, their head's bigger, it will hyperflex their neck, okay? It can cause airway problems and it cause cervical spine issues. So putting a blanket down, a folded blanket, to buy you an inch or two for their torso to lay on, allows their head to rest in a neutral position. Little kids, infants, toddlers, secure them in the car seat. Their car seat does a good job immobilizing them. That's why they're in the car seat, because it immobilizes them, right? And they're used to it. They don't fight it. They're used to the smell, the feel. They know where the Cheerios are hidden, for God's sakes, okay? So they don't fight that as much. They're more comfortable. You're providing one part of this that they're comfortable with, okay? Now, their safety seat, right? Because the integrity of it may have been compromised in the collision. You look at this thing and it's intact. We use them all the time. All right. State of New Hampshire, we're supposed to have child immobilization devices that are appropriate from infant to like the 6-year-old toddler. And so we have like one weird rolled up thing. There's no way. You can't have one thing that works perfect for all, right? So certainly if that seat looks like it may have caused some damage, yeah, don't. Rapid takedown. So God, we used to do this all the time. You have somebody standing up and the effort of you sitting down on my stretcher onto a backboard you could go paralyzed, which is horse shit. So we'd slide the board in underneath them. So this dude in the back now is his face up against a potentially contaminated board because the last group of people didn't clean it well. And he's holding the head. We then come in underneath the arms with our hands and grab the board, and down onto the ground we go, where we then have to shift them up on it, and then we have to strap them down. We don't do standing takedowns anymore. Now, this is out of the original spinal rule out protocol for New Hampshire. And while we don't have that protocol, we still have spinal motion restriction for a protocol. But this is just a good neurological assessment. So do they have a mechanism of injury and that we're worried about spinal? Yes or maybe. Okay. Maintain cervical immobilization manually. Okay. If it's negative, they have no mechanism of injury, we're not worried about it, okay, we don't have to do anything. We come up here and we go, all right, are they greater than, well, this changed towards the end of it, and it was under 9, because your 9, 10, 11, and 12-year-olds all basically think alike, which is they don't think a lot. But anyways, are they greater than 9? Okay. Right? Are they anxious or uncooperative? So if they're less than 9, anxious or uncooperative, they can't understand what we're saying. If the answer to that is yes, well, we need to stabilize them or motion restriction them, right? So today, collar, stretcher, all right? If the answer to that is no, so they're older than 9, they're cooperative, they're answering questions appropriately, do they have any altered mental status, do they have any evidence of intoxication? If the answer is no, we keep moving down the line. If the answer is yes, right, they're not answering questions appropriately, they don't know where they are, they don't know who they are, or we think they're drunk, guess what? They get a collar, they go on the stretcher. If do they have distracting injuries to themselves or others, right? If mom is so freaked out by her son's broken forearm that she's not interacting with you correctly, well, guess what? She gets a collar, she goes on a stretcher too. If all she's worried about is her arm, then she gets a collar and a stretcher. Now we look at spinal pain. Sir, do you have any pain in your neck or back? Yeah, my low back. Where? And he points to the side. That's the side, that's not spine. So we run our fingers down their spine from the base of their skull, their foramen magnum, all the way to the tailbone. Once we get to the pelvis, if they have no pain or tenderness to where we just palpated, we keep going. If they do, collar, stretcher. And then we look at a neurological exam, right? Hey, can you feel me touching you down here on your toes? Is this sharp or dull? Can you wiggle your toes? Can you extend your feet? Can you push with your toes? Can you pull with your toes, right? So pushing with your feet is extension. Pulling with your feet is flexing. And then we do the same thing with the wrists, right? Can you pull back with your hand, right? Can you push me away with your fingers, right? Can you squeeze, right? Soft, sharp or dull? If the answer to that is no, then we can have them tuck their chin to their chest, turn their heads to the side, left or right, and extend their head back. And if the answer to all that is no, if all this is normal, you don't even have to put a collar on them. Okay? If any of these are yes or maybes, then we put a collar on, put them on the stretcher. Now, if we're going to put a collar on them and put them on the stretcher, they are supposed to be supine. Our New Hampshire protocol says you may sit somebody up 30 degrees if they're having trouble breathing flat, if they're anxious flat, if they're nauseous, if you think they might get car sick, right? So everybody now just goes, well, I can sit them up, so I'll just sit them up on the stretcher. And they're sitting bolt upright. That's not what it is. It's stretch, it's stretcher, supine, or head elevated a little bit with a collar on. And you tell them, please don't wiggle around, okay? So this is a very good neuro exam to tell you whether you need to collar and stretcher them or not. I get into trucks now with BLS crews or EMT crews even, and they're collared. And I'm like, how was the neck? Well, they get neck pain. That's not what I asked. How was the neck? Did they have any spinal pain? Or nope, I pushed on it. Okay, then why are they in a collar? Well, just to be safe. No. Do we give glucose to every patient just to be safe? No, we do an assessment and we decide they have a need for it. If they need glucose, we give them glucose. If they need baby aspirin, we give them baby aspirin. We don't just give everybody baby aspirin. So why are we putting a collar on every patient who has any sort of potential mechanism of injury? Okay, we shouldn't be. All right, so anyways, helmets. When to leave a helmet in place. If you have access to their airway and it fits snugly and you can ventilate them if you had to, you can leave the helmet on. Okay, football helmets, lacrosse helmets, all those things. If you can take the face mask off, right? Most coaches have little toolkits to fix helmets, so they've probably got screwdrivers. You can take that face mask off. Okay, then take the face mask off. You can leave the helmet on if you want. If you're going to take a helmet off a football player, you have to take the shoulder pads also, because the shoulder pads lift the torso up and it will cause hyperextension of the neck. Okay. As far as removing the helmet, one person comes in underneath. So first, somebody at the head holds the sides of the helmet for manual stabilization. The second person comes in, puts a hand underneath the neck and a hand on their chin. You now are taking over cervical immobilization or stabilization. The person that was at the top of the helmet sticks their fingers in underneath the helmet, pulls apart, and then slowly and gently tries to wiggle it off their head without moving their neck around a lot, okay? If they're in cardiac arrest, you just take it off as quickly and smoothly as you can, trying to maintain cervical immobilization. They're breathing, they're stable. You can take a minute or two to wiggle that off, okay? Now, key components, remember, and my AEMT, and the AEMT slides goes a little more into the whole helmet thing too, but I'm going to do a video probably in the next week or two of actual helmet removal, and I'm going to put that up on YouTube. My class, we'll practice that class. So key components, right? Central nervous system, brain and spinal cord. They regulate thought, sensation, motor. Everything works together to protect that. Our brain and our spinal cord get protected by CSF and the vertebrae and the skull. Closed head injury, skull remains intact, right? The brain is closed to the outside air. However, with a closed head injury, you get more swelling. So an open skull fracture, you actually may end up with a lot less brain injury because of that, because pressure can resolve. Neck wounds, massive bleeding and air emboli. Compression, right? Axial loading compression, excessive flexion, extension, or rotation. 33 spinal bones, right? 7, 12, 5, 5, 4. Immobilization and motion restriction are different things. Okay, you need to be proficient in them dependent on where you work. If you work in a state that allows motion restriction, then you just need to get through your AMT exam with boards and CADs, okay? But you need to be comfortable using a board or a scoop moving your trauma patients. And again, I think, you kind of understand why I prefer scoop by now. So does my patient have a mechanism of injury that I need to worry about? Okay, they do. C-spine stabilization immediately. Then do your assessment, okay? Your ABCs and your rapid trauma or your focused exam. Should they go to a trauma center? And what trauma center? Again, remember that different trauma centers have different capabilities. You're in the greater Boston area. You're not going to choose. You're going to call CMed and say, hey, I've got a status 1 trauma patient, trauma team activation, head and neck, and they'll go, okay, stand by for Mass General, and they'll tell you who you're going to. Okay, but you're in the seacoast of New Hampshire, and you might have Wentworth Douglas, which is a level 3. I think they're trying to become a level 2. Portsmouth, which is a very good level 2 with a very good neuro center, again, right? Parkland's a 3. The Elliott's a 2. Concord's Elliott's a 3 now, I believe. Concord's a 2, right? Who is closest and who does what you need appropriately? Okay, so you're treating a patient with a head injury, altered mental status, significant mechanism of injury to the head. Your partner thinks you should hyperventilate them. Ooh, we haven't talked about this yet. So in 99% of our trauma patients, if we are ventilating them, and our head trauma patients too, 10 to 12 breaths a minute. This is more ideally controlled with capnography, right? We want their end tidal CO2 to be 35 to 45, okay? 35 to 40 would actually be better. Most of our trauma patients, we do not want below
35. Okay. Now, there was some thinking, I mean, it's true. If you lower CO2, you will lower intracranial pressure within the head. Well, isn't that good? Well, so we used to hyperventilate all our trauma patients, our head trauma patients. The problem is that if you get to a CO2 of 25, your mortality rate climbs 700%. Because the way you decrease intracranial pressure with hyperventilation is you are dropping CO2 causes vasospasm, vasoconstriction. So what you are doing is you are causing less blood flow to the brain. And when you get to that magic number of 25, remember this is an average, some people it might be higher, you're basically causing a global stroke. So the only people we even consider hyperventilating now, and it's just a little bit, are the people herniating their brainstem. So if you start to see that Cushing's reflex, right, the hypertension bradycardia, then we want 30 to 35 for CO2, and that's it, no lower. We don't want to kill them. I can't imagine all the people that I was involved with that we thought we were doing the right thing by bagging them at 20 or 25 times a minute, and all we really did was kill them faster, or killed them, or made their already life-altering injury worse by causing a global stroke. So instead of being awake and drooling, now the dude has a massive stroke and he's in a wheelchair and he's bedridden. So I can't imagine that. So Cushing's reflex, ventilate them a little bit faster, 12 to 20, but keep an eye on that capnography. And if I could not monitor capnography, I would continue to bag them at 10 to 12 a minute. If I saw Cushing's reflex, I might go to 12, but I'm not really going anything more. Because remember, a good tidal volume with bag valve mask ventilation is also going to move more CO2 out. So bagging them at 12 will remove more CO2 than them breathing at 12. Okay, so that is head, neck, and spine. I'd like to thank you for your time with me this morning, and I'll see you in the next video.